Vasodilators, like adenosine and regadenoson, detect ischemia through the coronary steal phenomenon. When administered, these agents cause normal coronary arteries to dilate dramatically, increasing blood flow by 4 to 5-fold. However, stenotic vessels with significant blockages are already maximally dilated at baseline as a compensatory mechanism, so they cannot dilate further in response to the vasodilator. This creates a disparity in blood flow distribution. Blood preferentially flows to the normal coronary territories, which have dilated widely, while areas supplied by stenotic vessels receive relatively less flow. This uneven perfusion pattern, called perfusion heterogeneity, is what nuclear imaging detects. Healthy myocardium shows increased radiotracer uptake due to augmented blood flow, while ischemic regions appear as areas of decreased uptake because blood has been stolen away to the normal territories. This difference in perfusion becomes visible as a reversible defect on stress imaging. There are 5 main absolute contraindications to vasodilator stress testing that must be ruled out before administering agents like adenosine or regadenoson. First, active bronchospasm or severe asthma is an absolute contraindication because vasodilators can trigger life-threatening bronchospasm through A2B and A3 receptor activation. Second, high-grade AV block, second or third degree, without a pacemaker is contraindicated because adenosine further slows AV nodal conduction and can precipitate complete heart block. Third, systolic blood pressure below 90 millimeters of mercury is a contraindication since vasodilators cause systemic vasodilation that can worsen hypotension. Fourth, recent dipyridamole use within 48 hours, specific to adenosine, is contraindicated because dipyridamole increases endogenous adenosine levels, creating additive effects. Fifth, methylxanthine use within 12 to 24 hours, including caffeine, theophylline, or aminophylline, is an absolute contraindication because these agents are competitive adenosine receptor antagonists that block the drug's effects and render the test invalid. Screening for these contraindications, particularly asking about morning coffee consumption, is essential before proceeding with vasodilator stress testing. Adenosine causes AV block through direct action on adenosine receptors located in the AV node, which slows electrical conduction through this critical part of the cardiac conduction system. When adenosine binds to these receptors, it activates potassium channels and inhibits calcium channels in AV nodal cells, resulting in hyperpolarization and decreased conduction velocity. This effect is particularly dangerous in patients with pre-existing high-grade AV block, specifically second-degree, Mobitz 2 or high-grade, or third-degree complete heart block, because the additional conduction slowing from adenosine can precipitate severe symptomatic bradycardia or even asystole. In patients without a functioning pacemaker, this can lead to hemodynamic collapse. Therefore, high-grade AV block without a pacemaker is an absolute contraindication to vasodilator stress testing. The short half-life of adenosine, less than 10 seconds, provides some reassurance that AV block will be transient if it occurs. But in patients with baseline conduction disease, the risk of severe consequences makes vasodilator testing unsafe, and dobutamine stress testing should be used instead. Patients taking theophylline for COPD cannot undergo adenosine stress testing without appropriate preparation because theophylline is a methylxanthine that acts as a competitive antagonist at adenosine receptors, similar to caffeine. When theophylline occupies these receptors, adenosine cannot bind and exert its vasodilatory effects, rendering the stress test invalid and unable to detect coronary artery disease. There are 2 management options for these patients. Either discontinue theophylline for 12 to 24 hours before the scheduled adenosine test to allow clearance of the drug from the system, or alternatively, use dobutamine stress testing instead, which works through a completely different mechanism, increasing myocardial oxygen demand via beta-1 receptor stimulation. and is not affected by methylxanthine use. The choice between these options depends on the severity of the patient's COPD and whether they can safely stop their theophylline, as well as whether they have contraindications to dobutamine. In patients with severe COPD who cannot discontinue theophylline and may also have contraindications to dobutamine, pharmacologic stress testing may not be feasible. Dobutamine detects ischemia through a demand-based mechanism that differs fundamentally from vasodilator agents. As a beta-1 adrenergic agonist, dobutamine stimulates cardiac beta-1 receptors, which produces two key effects: increased heart rate and enhanced myocardial contractility. Both of these effects significantly increase myocardial oxygen demand, forcing the heart to work harder and require more oxygen delivery. In patients with hemodynamically significant coronary stenoses, the diseased vessels cannot augment blood flow sufficiently to meet this increased oxygen demand because they lack the capacity to dilate adequately. This supply-demand mismatch results in regional myocardial ischemia in territories supplied by stenotic arteries. The ischemic myocardium becomes dysfunctional and develops wall motion abnormalities that are directly visualized on echocardiography. Ischemic segments become hypokinetic, reduced motion, akinetic, no motion, or even dyskinetic, paradoxical motion during stress, while normally perfused segments become hyperkinetic. This makes dobutamine stress echocardiography particularly effective for detecting regional ischemia, as it provides real-time visualization of how different myocardial segments respond to increased workload, with abnormal wall motion serving as the marker of inadequate coronary blood supply. There are 7 absolute contraindications to dobutamine stress testing that must be excluded before proceeding with the test. First, unstable angina is contraindicated because increasing myocardial oxygen demand in a patient with active coronary instability can precipitate acute myocardial infarction. Second, recent MI within 2 to 3 days poses similar risks as the myocardium is still vulnerable, and increased workload can extend infarct size or cause rupture complications. Third, uncontrolled hypertension, SBP greater than 200 millimeters of mercury or DBP greater than 110 millimeters of mercury, is dangerous because dobutamine further elevates blood pressure, risking hypertensive crisis, stroke, or aortic dissection. Fourth, severe aortic stenosis is contraindicated because dobutamine increases contractility and cardiac output against a fixed obstruction, which can cause critical hypotension, syncope, or sudden cardiac death due to inadequate cerebral and coronary perfusion. Fifth, hypertrophic obstructive cardiomyopathy, HOCM, with obstruction is contraindicated as increased contractility worsens the outflow tract gradient and can precipitate hemodynamic collapse. Sixth, uncontrolled arrhythmias are contraindicated because dobutamine is inherently arrhythmogenic and can trigger ventricular tachycardia or fibrillation in electrically unstable hearts. Seventh, acute aortic dissection is an absolute contraindication because increased heart rate and contractility raise shear forces on the aortic wall, risking dissection extension or rupture. These contraindications reflect dobutamine's potent effects on increasing cardiac workload and its potential to cause catastrophic complications in structurally or electrically abnormal hearts. A normal dobutamine stress echocardiogram demonstrates hyperkinesis of all myocardial segments, which represents the expected physiologic response to beta-1 adrenergic stimulation. As dobutamine is infused and the dose is progressively increased, all segments of the left ventricle should show enhanced contractility, thickening more vigorously and moving with greater amplitude than they do at rest. This hyperkinetic response reflects adequate coronary blood flow that can meet the increased oxygen demands imposed by dobutamine's positive inotropic and chronotropic effects. Critically, any deviation from this pattern is considered abnormal and suggests underlying coronary disease. If a segment fails to become hyperkinetic, remains normokinetic when it should be augmenting, or worse, develops hypokinesis, reduced wall motion, akinesis, absent wall motion, or dyskinesis, paradoxical motion, during stress. This indicates that the coronary arteries supplying that territory cannot deliver sufficient blood flow to support the increased workload. These wall motion abnormalities are the primary markers of ischemia on dobutamine stress echo, distinguishing viable but ischemic myocardium from normally perfused tissue that responds appropriately to the inotropic challenge. When a myocardial segment demonstrates normal wall motion at baseline but becomes hypokinetic during dobutamine stress, this is a classic finding of ischemia and represents a reversible wall motion abnormality. This pattern indicates that the myocardium in that region is viable and functioning normally at rest when oxygen demands are low, but when dobutamine increases heart rate and contractility, thereby increasing myocardial oxygen consumption, the coronary artery supplying that segment cannot deliver adequate blood flow to meet the heightened metabolic demands. The segment becomes ischemic under stress and consequently loses its normal contractile function, appearing hypokinetic, reduced motion, or potentially even akinetic, absent motion, on echocardiography. This reversible dysfunction strongly suggests the presence of a hemodynamically significant stenosis in the coronary artery feeding that territory, meaning the blockage is severe enough to limit flow during periods of increased demand, even though resting perfusion is adequate. This finding typically warrants further investigation with cardiac catheterization to define the coronary anatomy and assess the need for revascularization, as the viable but ischemic myocardium would likely benefit from restoration of normal blood flow through either percutaneous intervention or bypass surgery. A fixed defect on nuclear stress imaging, characterized by a perfusion abnormality that is present on both stress and rest images, indicates prior myocardial infarction with resultant scar tissue formation. Unlike reversible defects, which represent viable but ischemic myocardium, a fixed defect reflects non-viable dead tissue that has been permanently damaged by a previous infarction. The defect appears on both stress and rest imaging because the infarcted myocardium cannot take up the radiotracer under any conditions. There are no functioning myocytes present to accumulate the perfusion agent regardless of blood flow status. Critically, this finding does not represent active ischemia. It represents established scar tissue. The clinical implication is extremely important. These segments will not benefit from revascularization procedures like angioplasty or bypass surgery because the myocardium is already dead and cannot recover function even if blood flow is restored. This distinguishes fixed defects from reversible defects, where revascularization can restore perfusion to viable ischemic tissue and improve cardiac function. In practice, fixed defects help identify prior infarct locations, assess the extent of myocardial damage, and guide treatment decisions by indicating which territories have recoverable function. Reversible defects versus which are permanently scarred. Fixed defects